政府代表嚟啦。開啦。OK， 咁唔該晒啊。
Thank Mr. Sun and the Permanent Secretary. I apologize for last time because I kept you waiting. I didn't realize. And this time I make sure that I won't keep you waiting. Secretariat's background brief and also the admin's paper have been circulated. Perhaps I will ask the DS to take the paper, to walk us through the paper. Well, we have worked out a projection model, and we have taken into consideration the unique situation of a different discipline. We have spoken to doctors, dentists, and nurses, and we have worked out the manpower projection model. And we have also listened to the views of the Manpower Committee and also the relevant bodies. We have to make adjustments before we can give you the exact figures. In relation to the preliminary manpower projection, we see that in the near future and for some time there will be a shortage. The situation is similar to the forecast made by the Hospital Authority. We have taken reference of the HA's manpower forecast. And in the next 3 years, that is 2016-17 to the cycles starting from 2019, there will be more places in universities made available. This involves university resources and the ability to train more people. We are actually looking into it with universities. Hopefully, we will be able to announce the figures in the near future. That's your presentation. Any questions from members? If not, let me start. The universities have their model to make a forecast, and it's quite accurate. And I reckon that they will take into account historic figures. And we see in your paper a very simple table. The Hospital Authority gave us manpower projection to us before. They have also taken into consideration historical data with regard to service demand, taking into account changes in our demography and change in service demand. I believe at that time the hospital authority gave us a breakdown of the projections of different disciplines. If you use past figures, and if that figure shows there has been manpower shortage, then the findings will still be the same. If you take into account the historical figure and service demand, say 100 for every 10,000 patients you need 100 doctors. Then for 2016, there will be 15 patients, so you need an increase of 50% in number of doctors. But the fact is, 100 doctors for 10,000 patients is still quite stretched for doctors. And I asked you, if service is to be improved, how much more in manpower do you need? But you did not give me a figure. Yes, you're right. And last time when the Hong Kong U presented the modeling, they explained that it was a neutral approach using past figures. And the special characteristic is that it is dynamic. Say, for example, if you would like to improve service, then the ratio between doctors and patients, they will be able to work out the extra number of doctors that you need. That's the model. That's why it's complicated, because there is flexibility. And you asked if there is a service improvement, how it will change the manpower demand. I'll defer to Dr. Zheng. Let me say that for the HA figures, we take into account workload. Say, for example, for nurses, there are different types. Say, for example, there are groups that rely more on care, and for nurses, there are those involved in direct dealing with patients and those not, and we work out the number of nurses we need. The point raised by the chairman is a bit difficult to deal with. Yes, Chairman, you have reasons to ask that question. We try to tackle that. Say, for nurses, we don't look into how much time is spent on each patient. In a less than ideal situation, we talk about the time required per work unit to reasonably care for the doctor, for the patient. And there is about 50%, so which is the adjustment. So we're talking about a change of 5 to 10%. But it may not fully address the problem. But that is a model for the projection. Some members are waiting to ask questions, perhaps 3 minutes each. I have a lot of questions. Well, we will formally start, because there are members who would like to ask questions. According to the permanent secretaries, they said that they have already taken into account service improvement in the projection. Well, I have 2 things that I ask for. Some information from the university and some information from the hospital authority. Well, reality is that the HA projection is based on service demand. And if there is insufficient funding, no matter how large the service demand is, you may not be able to recruit, because it has happened before. And now the projection is to 2040 something. It's quite far into the future. You may think that it will be difficult to estimate the future funding allocation to a hospital authority. But regardless of accuracy, from now to 2041, the term used by the government is establishment. So how many doctors are there in the establishment every year? You give the impression from the information you've given that there is a shortage. Well, if I give you 360, and there may be an increase of 5% in manpower, and there will only be limited service improvement. So you work out the establishment every year, taking into account the funding allocation, and if you don't have the money, then you won't be able to recruit. You have to take into account number of people retiring every year. You can work that out. Also, those who would resign, maybe a little bit more difficult, but you can still work it out. And there are also people with whom you will not renew the contract, even though they would like to stay. So we're talking about wastage, and there's also the number of number of graduates every year. There are also people coming from other ways, say limited registration from overseas. Those who have passed the licentiate, whether it is a right projection or not, you will at least have a basis to make your adjustments. And my time's up, so I will leave the second part of my question later. Mr. Poon Siu Ping. Thank you. Just now, you talk about the projection model. It seems that to 2040, no, for 2041, there will be manpower shortage. You have to consider increasing training. That is very important. With an acute manpower shortage, well, I think that for serving doctors, they have to retire at the age of 65. And in paragraph 12, you talk about the HAs exploring the feasibility of extending the retirement age of doctors to 65. So in the coming decade, how many nurses and doctors would retire, and how many of them would be re-employed after they have retired? And if they are re-employed, are they going to take up the work when they left? And a lot of overseas doctors would practice through registration. And most of them will be in the private sector, or will they be in the public sector? P.S. Just a quick answer to Mr. Poon, and then Dr. Zhang will supplement with detailed figures. Mr. Poon is right. It doesn't have to be all the way to 2041. In the near future, we have a manpower shortage. We asked the Hong Kong U to work out the model to together with the HA. The HA will only cover the public sector, and we look at it as a whole. We have yet to work out the model because there are many new developments. There are many variables. We don't wait till we see a shortage before we do something. And recently, there has been discussions about a possible extending of retirement age by the HA, like the government, from 60 to 65.
嗰個預測嗰個供應嗰度咧係有個。
And this is a new factor we have to consider in the forecast model. At the same time, the licensing exam organized by the Medical Council for Overseas Doctors, when we look at the recent history we have around 30 doctors from overseas joining our forces every year, and the frequency of the licensing examination has been increased from once a year to twice a year, and at the same time, the examination has been catered to Hong Kong students who are studying overseas, and as such, the time or the schedules of the examination has been catered for those who are studying in the Southern Hemisphere. We are trying to offer greater convenience to Hong Kong students who are studying overseas. So in the past, we have seen around 60 to 70 students taking the examination, which has been a great improvement. And these students are likely to come back to Hong Kong, and we'll have more students taking the examination. So this factor must be taken into consideration as well in the model. This is a major factor. In the coming years, even if we won't have a very accurate forecast figure, we have to take into account the doctors who are re-employed by HA. So in the coming years, we will have an enhanced supply of doctors. So this is a trend we can see already. But for detailed figures, perhaps Dr. Cheung can give more. I'd like to talk about several things. First, doctors who join us after the 1st of June, their retirement age has been extended to 65. As long as these doctors joined after the 1st of June, they will only have to retire at 65. But for those who joined before that date, the arrangement is unchanged. We are studying the feasibility of re-employing doctors who have retired, pending more discussions with the relevant departments. And we also launched a scheme for doctors and allied health professionals, and they can be re-employed on a contract basis after retirement. And these doctors and support staff can be re-employed on a 2-year contract. And this is a scheme we will review when we conduct a review on the retirement age. But so far, the response has been very positive. And we see that 60 to 70% of the retired doctors and support staff have shown interest in this scheme. And the figures shared by the Permanent Secretary were also correct. We have enhanced the frequencies of the licensing exams from once to twice a month, and 144 overseas doctors would be eligible for for the examination, and the passing rate for the past year has reached about 30%. And we will study whether or not we can further relax the number of candidates every year from 144. And since the passing rates differ every year, we'll look into that. And for doctors, for overseas doctors on limited registration, the work is ongoing, and we have less than 10 such doctors every year. We are not sure how many doctors will go into private practice because this is really up to them. But for those on limited registration, they can only work in the hospital authority, universities, and so on. They cannot practice outside of this scope. Chairman, I'd like to supplement. You might be interested in the supply of doctors in the coming years. I'd like to stress that we are not only increasing the number of HA doctors, we have also stepped up private-public collaboration under the HA. And as the chairman mentioned before, private doctors have very different workloads as public doctors. If we enhance the public-private collaboration, we can leverage on the manpower in the private market, and as such, we do not have to increase the overall figure, but still enjoy an enhanced capacity. So we have factored in all these points, and as we come up with the projection figures. Any follow-up questions? Next, Mr. Yu Si-wing. Thank you, Chairman. On the shortage of manpower for professional healthcare staff, we should not only just look at the number of existing staff. We should look at the match of resources as well, and we have to think about how many patients each doctor or nurse has to deal with every year, and we also have to consider optometrists, occupational therapists, and so on, and there should be standard ratios. We should look at the number of staff we have to the number of patients we have. And we should also take reference from overseas standards. For instance, in the public hospital, how many doctors or nurses should be assigned to each patient? I'm not sure if the government has come up with this kind of standard ratios before. In normal circumstances, how many doctors or nurses should be assigned to each patient, and what are our existing ratios in Hong Kong? Have you done such studies? If we are to launch the VIHS or voluntary health insurance scheme, if we enhance public-private collaboration, we might be able to improve the ratio of doctors to patients. And if an improvement is possible, what is the target ratio we want to achieve? For instance, the global standard for nurses might be 1 nurse to 6 patients and so on. Have you conducted any studies like that? This is mainly to do with the HA, so perhaps Dr. Chang can tell us more. First of all, I want to address the ratio of doctors to patients. When the HA conducts planning, this is not the way we go. If we compare ourselves to other countries, well, we have to consider the unique situation in Hong Kong. Our resources are very focused. When we consider the ratio of doctors and nurses to patients, we have to think about our healthcare mode. And under different modes, the demands for healthcare staff would be different. our current approach is to look at their workloads and demand and service demand, and as the chairman said, when we estimate the workloads, we would adopt the approach of workload units for new cases and existing cases. Well, we will distinguish between new and old cases, major and minor surgeries, the frequencies of their shifts, the number of checks they have to conduct, and so on. And we'll look at the our demographic structure and the number of elderly citizens who need attention. I think this is an approach which is better suited to Hong Kong. If we take this approach overseas, or if we adopt an approach that's practiced in other countries, it might not be feasible. For example, in Australia, the ratio of doctors and nurses would be very high because the patients are really dispersed. So we would look at the actual needs and demand when we derive the figures. I'd like to follow up on my question. Yes, you have time. Yes, you do have some time left. In terms of statistical analysis and judgment, the reality is that we have adopted this approach for a long time, and with the increasing number of patients and with an improvement in living quality, the work burden on the staff might be lowered, and our healthcare professionals have higher expectations on living quality and they wish to work less, for example. And is there a plan to constantly decrease the workload of healthcare professionals? Can we have some flexibility? Or are you going to say this is what we will do and will not change anything? And after health insurance scheme is introduced, can you really ease the workload of healthcare professionals, and by what percentage? Permanent Secretary. I fully understand why you asked that question, and I can tell you for sure that we agree with what you said. Long-term speaking, we have to ease the burden and work pressure of healthcare professionals in order to enhance service quality. But the reality is that the waiting times are extremely long. We are talking about years, and the wards are really crowded. But that said, even if we derive a set of standards right now, we cannot possibly introduce a lot more healthcare professionals overnight, even if we have the resources, even if we conduct extra training immediately. We also have to think about quality. If we are to expand the scope of training, we must not neglect the quality of our healthcare professionals. We understand that the current situation is unsatisfactory, and that's why we have done a lot. In terms of doctors, we have done a lot of things, including introducing private-public collaboration, and perhaps Dr. Chen can give more on that later on. We have done work on chronic illness patients, and by collaborating with private doctors, some hospital leavers can seek health in the private sector, and this would alleviate the burden on our frontline doctors. Under the private-public collaboration scheme, it's not just about shortening the waiting times. We also want to ease the burdens on HA doctors. So this is a win-win situation. And we talked about recruiting overseas graduates, and we are now discussing with UGC on what to do with the university places.
一般嚟講，佢
But we have to bear in mind quality, because the threshold is a lot higher. So we have to make sure that there are suitable students before we can expand the number. We also bear in mind the service demand. If the demand is somewhat lightened, then we will consider how to take away this or alleviate the stress faced by the hospital authority. Pressure is really high, so it's meaningless to put in place some kind of pressure indicators. But it doesn't mean that we're not going to do it. We'll wait for the situation to improve before we study it. At the end of the report, we find that about 3 to 4% of surgery in ambulatory setting. We reckon that it will be improved. It will be changed from 86% public, 40% private to 81% public and 90% private. Some common operations will be dealt with in an ambulatory setting in the private sector. But we're talking about a huge demand because of the aging population. It's difficult for us to make a projection on the improvement of pressure faced by manpower because of these two factors. Dr. Joseph Lee, we understand that we're here to talk about health protection and not manpower in the healthcare sector. And my understanding is that if we have the healthcare protection scheme, then with more manpower, it will help. So we're not just talking about doctors, nurses, and manpower. Well, even a layman knows what to ask. What about work pressure, doctors, nurses? And I heard from Dr. Zheng that there are some workload indicators. It's a workload index. It's been in place for about 3 years under the HA. It's nurses and doctors. Dr. Zheng said that Hong Kong is special, so we cannot simply adopt overseas practice. We have to work out our own. But you did not announce the index. If you use the workload index, and on page 3, you will find the table. In 2020, there won't be any more shortage among nurses, and we'll be very happy. Let me give you some figure. Paragraph 8 on page 3. It says in 2014, there's a shortage of 500 nurses in the HA. I don't know what the workload index is. And the Nurse Association conducted a survey last year. Its ratio is nurses to patient. One nurse will have to care for 11 patients. So I would like to ask, by 2020, you say that there won't be any more shortage, manpower shortage. And by then, what is the ratio of nurse to patient be? And we're very happy to hear that in 2020, in the public sector, there won't be any more manpower shortage for nurses. And some patients will go to the private sector. Do they have enough nurses? I don't know about the situation there. What about the community? We need community nurses. I understand that we're not talking about just nurses and doctors' manpower demand. It's related to health protection scheme. But I do wonder whether we have enough nurses and doctors. And I haven't even talked about allied health professions. This subcommittee is about healthcare protection. But members have been very concerned that with the healthcare protection scheme, then says there may be manpower drain from the hospital authority, and that's why the scope of this subcommittee has been extended to looking at manpower of doctors and nurses, because they don't want staff to be poached from the hospital authority because of the health protection scheme. Well, I wonder why they say that by 2020 there won't be any more shortage. And in 2015, there is only a shortage of 360 doctors and 150 nurses. I think it must be a joke. But we're talking about last year, a shortage of 500, and 2015, only 150. So does it mean that under the workload index, they have passed? P.S. Well, I will answer in principle, and I will defer to Dr. Zhang for details. This projection to 2020, saying that there is no manpower shortage for nurses, objectively is right, because we are only looking at the current situation. Well, say for example, currently under the HA there is a shortage of 300 nurses. In the coming few years, both the private sector and the public sector are training nurses. And there are many different, and there are also other organizations that are training nurses. And on top of that, of course, there is the self-finance there are self-finance programs. So in the past few years, there has been a lot more nurses under training. We reckon that in 2022, given the current service demand and the current situation, that will be sufficient. But of course, you will have to address all the problems we have before you can make improvements. We think in our projection that there should be sufficient supply of nurses in the public sector in 2020. And Dr. Zhang will supplement about service improvement. Of course, we have to take into account resources to be allocated. If there is sufficient resources, of course, we can make improvements. So this is just a figure on manpower. And as to whether there will be any improvement, we will have to look at the situation then. Well, what if there is a financial and economic downturn? Then there won't be enough money to recruit nurses. For nurses, it's easier to deal with, because there are many ways to train nurses from the universities, from the HA, from community colleges. And the years of training required is shorter. So when the health protection scheme is implemented, I believe the hospital authority will expedite the training of nurses to cope with that. So when we talk about no shortage in 2020, it's based on the current service level. It doesn't mean that we don't want to improve on service, but we have to first address manpower shortage under the HA before we introduce improvements in the service. That's the same for doctors, and I would defer to Dr. Zheng. Dr. Lee's right. You asked whether we have a sufficient number of nurses in 2020. But let me first clarify. The model of manpower projection is a fine-tuned improvement of 5% based on the current situation. And we also take into account service demand to work out the manpower projection. And if all remains the same, then in 2020 there will be a sufficient number of nurses. But the fine-tuning is not ideal. It's quite, there is a gap between from the ideal situation. But we think this is a more practical approach. That's all. Because, after all, it's difficult to define what is ideal. And in the past few years, there are more and more nurses who graduate, say about 2,000 a year, and there's a wastage about 1,000 a year. So we have an actual increase in number of nurses every year. We increase service, and it will take up about several hundreds of nurses, and the remaining nurses will be assigned to the front line to replenish the wastage in wards. In 2010 we worked out that there's only a shortage about 1,000 nurses, and the recent figure is about 500. It's not ideal, but it's a practical projection. We have to keep reviewing the figures because there has been constant change in the mode of operation and the situation. A lot of members are very concerned about workload and shortage of nurses in the public sector. And I can tell you that there shouldn't be many problems in the private sector, but in the coming few years there may be an increasing demand. People may switch from the public sector to the private sector, and there may be more nurses being trained. In RCHEs, residential care homes for the elderly, and in the social welfare sector, it seems that there is a shortage of nurses, but my understanding is that there is not actually a shortage in the market. And I think the reason is, say for example, the work environment in an RCHE and the promotion prospect. And in RCHEs, there may not be sufficient training to churn out nurses that are familiar with the environment in a residential care home for the elderly. So apart from boosting the figures, you will have to take into account the training, the scope of training, not just nurses, doctors as well. But using nurses as an example, maybe we'll have to strengthen the different areas in the training courses. Say, for example, care for elderly people. And after they receive the training, maybe when they graduate, they will be more ready to work in RCHGs.
我頭先就要求你話醫管局嗰個。
Just now, I asked for the HA's establishment, wastage, retirement rates, the recruitment of new staff, and so on. Well, I want figures for other grades as well, for example, nurses. And that's very important because when I look at your forecast for 2020, the establishment has increased by 10,000 people. And you recruit 13,000 more people, and so there will be no shortfall. So we need detailed figures. So the most important thing is the change in establishment and estimation. So with those figures, we can see whether the extra manpower can meet the increase in establishment. So those actual figures are very important. While we are at that, I'd like to talk about something else. Is the current establishment at a rather low level? If the establishment level is fairly low, if you only the level will remain the same. So we have to consider the workload index. You need to know the establishment before you can argue on that. Dr. Kiki Kwok, I don't know where to start, to be honest. The paper is very coarse, and even though it mentions the model by the two universities, when you look into the details, the paper has not mentioned indicators for doctors, nurses, and other healthcare professionals, and it didn't mention the number of daytime and nighttime nurses. Without these figures, I don't know how the government came up with the conclusion that by the year 2020 there will be no shortfall for nurses. And as the Permanent Secretary said, for nurses and therapists, apart from the healthcare industry, there is a serious shortfall in elderly homes, especially private elderly homes. As you all know, the government has not enhanced or given extra subsidies to elderly homes, and they have tried to dodge their responsibility by introducing the voucher scheme. There's no, the government has not provided any career letters for these professionals. So, in fact, they are the roots of the problems. Everyone knows that no doctors and nurses would like to work in elderly homes now, even though there is a demand. Unless you can provide extra information to tell us more about the situation in the face of population aging, you should provide more information on the nurses and therapists required in elderly homes. And for dentists, as we mentioned multiple times, the government is not providing enough dentists for Hong Kong, and as such, there is a shortage, and the government is powerless in providing more dental services for Hong Kong people, especially the elderly. Right now, only the most essential dental services are provided, and for your estimations in 2016-17, can you increase the figures or increase the number of dentists in the coming years to meet the aging population? Thank you, Chairman. Perhaps Dr. Chung can talk about the indicators, and let me address the other two questions. For elderly homes, I agree with Dr. Kwok that I'm aware of initiatives. I'm aware of demand for initiatives like the elderly voucher scheme. We are fine-tuning our manpower resources, and discussions have been ongoing with the Social Welfare Department and the Labor and Welfare Bureau, and we are fine-tuning the manpower supply, and the figures are all encompassing. But compared with the private and public sectors, the figures for the welfare sector is not very high. The main considerations for doctors and other professionals is the working environment and whether or not, mentally speaking, they are prepared to work in such institutions. So this is something we have been discussing with the Social Welfare Department. But I do agree with you that we have to get going. But at the same time, we would study what we can do to improve. For dentists, we know that there is a shortfall. And as you know, we will launch an elderly scheme for dental checkups. And if necessary, we would provide dental services for them as well. Or there might be means tests under the scheme. And we'll first target elderly people who are above 80. We would deploy private dentists, and hopefully by the end of this year, we can roll out the scheme for elderly people above 80, and later we can extend it for all elderly people age 70 or above. We do have a lot of dentists in private practice. We have over 1,000 dentists, actually, and they can deal with thousands of patients, and this arrangement is more ideal than hiring extra dentists. And at the same time, we want to increase the number of dentist students, and we would work with the Dental Council of Hong Kong to facilitate Hong Kong students who are studying overseas to take exams in Hong Kong. For indicators, perhaps Dr. Cheung can tell us more. For the Medical Council of Hong Kong, we do have a set of indicators. First of all, we would consider the workload units. For example, the number of doctors or nurses we need in each work unit. And secondly, for each ward, how many work units do we need? And by multiplying that number with the number of staff, then we have the total. And as I said, there might be room for fine-tuning or adjustments. But I cannot, come up with an overall figure. Chairman, I don't know what to say. How many extra dentists do you plan to introduce by 2016 to 17? And second, in wards, we often have only 2 registered nurses at the night time, and under the basis, can they provide us with more concrete estimations? Mr. Wuchiwai, Permanent Secretary, can you address my question first on dentists? As I mentioned already, we need to increase the number of university places for doctors and dentists in the next triennium. And right now we are working with the Education Bureau and UGC to see how much resources the government has and whether they can help increase the number of places for doctors and dentists. And we also have to negotiate with universities on how many more students they can take in. We have a dental hospital in Hong Kong and the Prince Philip Dental Clinic, and we have to look at the Prince Philip Dental Clinic. If they, how many extra places can they offer? Apart from the number of students admitted, they would also have to consider quality if they are to increase the number of places. This is something they must consider. Hopefully in the next 2 or 3 months they can come up with a figure on how many extra doctors and places for dental students they can introduce. For nurses, a lot of institutions are training nurses already, so perhaps there's little we have to do. For other professionals, Poly is training a number of students as well. This is something we should look at in the next 3 years. And on the long term, we have to think about the facilities as well, because this is a chicken and egg dilemma. I cannot provide such figures now, but I can assure you that we will certainly increase the figures. Mr. Wuchiwai. Thank you, Chairman. I've been at this meeting for quite a long time. Well, for long-term housing policy, the approach is demand-based, and for healthcare policy, it seems to be need-based. But the government wouldn't share figures on resources with us, so we have no idea how they estimate their manpower needs. The government mentioned the fine-tuning of working environment. I'd like them to elaborate on that in a moment, and whether or not it can ease the burdens on our healthcare professionals. And in paragraph 3, because of population aging, the healthcare will be in great demand in coming future.
We're talking about we need 9 times more of beds for elderly people. And for those over the age of 65, it accounts for about 1/3 of our population. So unless we try to compress the demand, we see from these 2 sets of figures alone that we do need a significant increase in medical resources. But the government tried to keep medical expenditure to under 17% of government expenditure. PS, you've said many times, well, the future manpower planning depends on resources available. Does it mean that you have a straitjacket of 17%? I'd like to hear from the PS in this regard. And the FS said a number of times that there needs to be value-adding services. Does it mean that the HA will have to save 2% in the coming 3 years? PS, I will answer the first 2 questions first. And Dr. Zhang will answer about the fine-tuning. The 17%, I think it's misunderstood. Why is there a figure of 17%? Is because that at that time the amount of expenditure spent on healthcare is just about 15% or so, and it has to be increased to 17%. And over a number of years, it's increased to 17%. So it's not the case that it has to be kept at 17%. And it was also said back then that there will be a review of the percentage of expenditure on healthcare later. And it's not the case that we only have eyes on the present. Last year, the FSTB, well, you may know about that report of the long-term strategic, long-term physical planning working group. It's because of healthcare that there is a huge gap, and there are already a set of figures, and that's based on the current situation with an aging population, how much financial implication there will be with a certain percentage of service improvement. We are aware that there is a long waiting time. Currently is because of a difficulty in recruitment. We have to make sure that in the coming few years to recruit sufficient number of people. That is now a shortfall in the HA. So we work out the number of doctors and nurses, the additional numbers of doctors and nurses. That will be our first step. And at the same time, we look at the long term. With sufficient number of nurses and doctors, and if there is sufficient manpower, we can make further improvement.
都好，譬如醫管有資源足夠俾佢都好咧。你今日請唔到冇市場上。
Well, it's because there is no surplus labor in the market that we cannot recruit. Doctors are different from other professions. They have to stay in the same sector, and they always start in the HA. So we can increase the number of places in medical school. We have to make sure that there are vacancies. We know that a lot of Hong Kong kids are studying law overseas. And if we can tap into that, we're talking about an additional 70. Currently, there are 350 being trained in Hong Kong, and there will be an additional 70 from overseas. This is an additional source. And about a private-public partnership, we can make use of doctors in the private sector to help alleviate the pressure. We have to make sure that there is sufficient number of doctors and nurses recruited before we can think any further. What about the fine-tuning? You haven't explained about the 5%. Well, HA it cannot be exempted, but it's not 1%. For the first year, it's only 0.5%. The reason is that when it comes to financial management, no matter what organization you are, you have to consider whether to just do exactly the same as you've done in past years. With an increasing service demand, you will have to review your work procedure to see if there is any room for streamlining. And this is a way to save. You give us the amount saved, and then we will look at what additional service you'll need and then give the money back to you. We have an aging population, and the long-term physical planning report indicates that healthcare will account for a lion's share of government expenditure. So the HA will give us a small amount, and we will give them back a huge sum. We would like them to look at their work procedure in different ways to see if they can streamline anything to make any savings so that the amount saved can be used in new services. And as to how much can be given back to them, it depends on the situation. Then this is about the value adding approach. What we would very much like to do is that with a change in our demography, with an aging population, how much is demand and what manpower level we'll need. So we first start in our study the scenario of dealing with current demand, say geriatrics, orthopedics, the service demand, and with the current manpower level, how is the work done? Say, for example, outpatient operation, direct dealing with patients. And if, well, with a shortage in the first place, and if you make a projection, it will be based on shortage. Normally, what we hear is that there is not enough time spent on patients and workload is too heavy. And we will add about 5 to 10% on the basis. So we will have a situation when the situation has improved by about 5 to 10%. So it won't be the situation that when the baseline situation is poor, then no matter what you do, the future will be just as poor. We have already added 5 to 10%, so the situation will not be just like in the baseline situation. So you add 5 to 10% to the baseline. So for the table on page 3, manpower shortfall, you have not taken into account additional service demand and the manpower required as a result. Yes, we have, because we're talking about an overall demand. It has included the 5 to 10% fine-tuning, taking into account change in our demography, wastage and increase, whether there will still be manpower shortfall at different stages. Mr. Yu Si-wing, you want to ask follow-up question on manpower? Under the healthcare protection scheme, as you know that there are a lot of people who live on the mainland, but when they fall ill, they will come back to Hong Kong to seek treatment. I don't know if the government has done any survey to find out the number of people who are living most of the time on the mainland, and what is the percentage of the service demand in the public sector. When we launched the health protection scheme, can they go to use the mainland healthcare system? Will there be some cooperation, say for example, to have hospitals in Shenzhen or Zhuhai built? You know that we have the Hong Kong-Zhuhai-Macau Bridge. There will be more and more border control points linking us to Shenzhen, and the number of people who live on the mainland will increase. So would you consider allocating resources, say for example, start with 2 cities to extend the coverage to more cities in the future? But this is nothing to do with manpower. It's the design of the healthcare protection scheme as to whether service can be provided on the mainland. But we're talking about surplus. Well, the surplus manpower can go to mainland to serve Hong Kong people. Okay. P.S. Hong Kong people living on the mainland or retiring on the mainland, they seek medical service back in Hong Kong, and we have already taken that into account. We worked out the figures on the base of population. But with a huge service demand, then that group accounts for only a small percentage. And if you reach, say, 80, then demand for hospitalization has increased by several folds. We hope that with more people taking out health protection schemes, then they will go to the private sector, because a lot of them can be done in an ambulatory setting. And in this way, the demand for public health care will be alleviated. Some people may think, well, the cost may be cheaper on the mainland. And as to whether people can use the scheme and receive the service on the mainland, it depends on the insurance sector. Whether the claim will be met depends on the company. There are some insurance policies that covers operations or treatments received or done overseas, but we're only talking about, say, America. The market may change to adapt. As you know that there are Hong Kong universities running hospitals on the mainland, and Hong Kong people living there have started to use the service, and this is a start. I've been to Zhuhai, Zhongshan recently. There are a lot of residential developments who target Hong Kong retirees or those who are going to retire. A lot of Hong Kong high-ranking officials have already purchased properties there. This is a starting trend. So have they conducted any survey to find out how many people will live on the mainland? And if they can work out the figure, and if it turns out to be a substantial number, and if the protection scheme can be extended to the mainland, then pressure may be alleviated. We're not talking about the entire Pearl River Delta, but can it be, say, Zhongshan, Shenzhen, Zhuhai? Because I know that a lot of people actually live there. And we can discuss with insurance companies to find out whether the scheme can be extended to several cities on the mainland. We'll have to first launch the health protection scheme before we explore other issues. People who live on the mainland long term, say for example, retired middle class people, they may very well have purchased insurance policies on the mainland. The market has responded. Yes, if the health protection scheme is done well, maybe mainland healthcare can be covered. Well, first of all, I asked for the projected establishment, wastage, additional recruitment from local schools, from overseas. P.S. You made the Hong Kong U model sound brilliant, but I have yet to hear how it works. Can you maybe use some examples to illustrate? Say, for example, the model can take into account and change in service demand, and it will respond to a service improvement, and it responds to the change in retirement age.
係點樣做法？
Can you illustrate the algorithm with concrete figures so that we know how it works? And this way you can give us more confidence. And I also want the Permanent Secretary to tell us how this model will operate. You mentioned that you will train enough healthcare professionals so as to repeat the scenario in 2003. At that time, you didn't have enough money and resources, and as such, you failed to recruit the staff. This is a very interesting point. Most new recruits by the HA are fresh graduates. Let's say if you fail to recruit enough people this year, let's say if the shortfall is 50, according to what the Permanent Secretary said, you won't decrease the number of places for medical students, because according to your logic, the HA can recruit more of these doctors once they have the money. No, that's not what I meant. For locally trained medical graduates, the HA is obliged to hire all of them. Let's say if there are 100 fresh graduates and the HA fails to recruit all of them, according to your logic, are you going to decrease the number of university places for medical students? That's not the case, Chairman. We are adopting the forecasts or the projection models by HAU and the Medical Council. Well, simply speaking, let's be straight here. What is the government's approach? Are you going to hire as many fresh graduates as you can? Let's say there are 100. Let's say you have a shortfall of 100 this year. What will the government do? Are you going to just let it be, and will you adjust the number of university places for medical students? We'll certainly make an adjustment, but even after an adjustment, you have to wait for 6 years before you see any change. So these adjustments must be done carefully, and we have to make sure that when these students eventually graduate, DHA can hire all of them. And we have to make sure that DHA can hire all of them, even during years of economic downturn. In the HAU model, is there any mechanism in place to deal with this situation? Let's move on to the next item on the agenda. Thank you very much, Dr. Cheung. Matters arising from the meeting on the 11th of March. The government has circulated the relevant papers. So again, let's invite the PS to walk them through with us. They're in response to questions raised on the 11th of March. During our meeting in March, some members suggested us to prolong the consultation period, and as such, we prolonged it by a month, and it ended on the 16th of April. We received about 600 submissions, and we are consolidating the comments. Generally speaking, comments are rather supportive of our proposal to conduct a healthcare reform, especially aspects which serve to safeguard consumer interests, for example, guaranteed renewal and so on. The insurance sector also raised some technical comments, for instance, minimum coverage, cost sharing, inherited diseases, and so on. We will continue to work with the insurance trade to come up with consensus. And in our letter, we address different questions raised by members last time, for example, pre-existing conditions. So if members have other questions, we can address them today. No questions. Mr. Yu Si-wing. Chairman, I'd like to follow up on my own question from last time. For the VHIS, we hope more young people would join in because the cost would be lower for the insurance companies if we only have older people or people with existing conditions joining in, then there would be a great burden for insurers. So under VHIS, as long as you pay the premium, you will be covered. The government seems to be listening to different views on the issue. And if, in case you fail to pay the premium after a specific period, will you still be covered? Or what if someone fails to be covered anymore? Or is it that the insurer will continue to insure that person, but the coverage amount might be lower? For young people, they might be very healthy during the first 30 years, but 30 years later, they might not have the money to pay for the premiums anymore. So what should they do? For retired people, it's hard for them to take out insurance because of their age or pre-existing conditions. And for those people, they might make claims 1 or 2 years into their plan. So will the government tackle this issue? For young people who have paid premiums for a number of years, is there anything to help them if they fail to pay after so many years? Is there any protection for them? After, is there anything you will do so that people will have more confidence in VHIS when it's eventually rolled out? This is really to ease the burden on insurers. Permanent Secretary. For healthcare insurance, we have to look at the unique situation of Hong Kong. The scheme is voluntary in basis, and as such, the protection is solely offered by insurers instead of the government. In some countries, healthcare insurance is a kind of social security, and it's only called insurance by name. And we want to enhance transparency and openness and encourage more people to take out healthcare insurance. And for most people, the premiums will depend on the level of risk. In terms of incentives to young people, the key is to educate them on the importance of health insurance. When they are healthy, the premiums will be relatively lower. With the minimum requirements in place, they will continue to enjoy coverage for a long time. For someone in their 20s or 30s, the premium for a typical health insurance plan is about $3,000 or under $3,000, and even when they reach 40, the premium is only $3,000 or $4,000. So it would be a big problem if they fail to pay that. It's a very complicated issue when if for some reason they fail to pay the premium. Some insurance products might be structured in a way that you only have to pay premiums for a specific period, and you can enjoy coverage beyond that. So it really depends on the insurer. We have to look at why they fail to pay the premium. So it's a pretty complicated problem. Any follow-up? I'm not sure if you have discussed this with insurers. Once the VHIS is rolled out, perhaps most young people would not be interested. They might prefer to pay a little bit more, maybe $10,000 or so a year, in investment-linked insurance plans. I have purchased such plans before. The coverage is much better than this kind of health care plan. They would, I think they wouldn't mind paying a little bit more in return for lifetime protection. If you put yourselves in their shoes, you might do the same as well. When later we might realize that most customers are are from high risk groups, and this poses great risk for insurers. You have to consider whether insurers would be able to bear such risks. You cannot force them into accepting that. Is there anything you have to resolve with the insurers before you roll out this scheme? Have you ever had such discussions with the insurers? Have you done your math? Yes, the insurance trade has come up with figures for themselves under the current situation. When we look at the past few years, for the 12 minimum requirements, the trade generally accepts most of these requirements. For example, the transparency, the inclusion of daytime care, advanced scans like RICT, and a lot of new policies in the market have already adopted these requirements. And for policyholders with pre-existing conditions, how will they be protected? In principle, the insurance trade agrees with that. But if pre-existing conditions are covered, the trade is of the view that the overall premiums will be increased, but we feel that the increase will not be substantial. But still, we will look into this problem and come up with a win-win situation.
And in the consultation a few years ago, a lot of people were concerned that they will not be able to take out an insurance policy because they have pre-existing conditions, and they very much wanted to take out insurance. And at the same time, there are concerns that if these people are covered, then will the policy be sustainable? There is a risk shared, but to what extent? We are talking to the insurance industry in this regard. We asked them if whether pre-existing conditions will be covered and what the level will be. I think that is the biggest issue that we're discussing with them. Hopefully, in the coming year or two, we'll be able to reach a consensus. Mr. Chan Kim Po. I think Mr. Yu Si-wing is trying to say that, well, for young people, these products are not very attractive. And I think he's trying to point out the problem that if the products are not attractive enough, then young and healthy people will not participate, and it will undermine the risk-sharing ability of the product. And I'd like to talk about items A and B. That is, in relation to coverage of pre-existing conditions, the government is asked for more information to say how much will the increase be. The paper briefly said that the overall situation can be given, but not a breakdown. They don't have the information or data in relation to the local market. Paragraph 1 says that the consultant assumes that there will be an overall claims amount increase by about 5%. That will lead to a broadly similar magnitude of increase in standard premium. But the insurance sector begs to differ. There may be an increase by 20 to 30% or even more. Currently, there is the high-risk pool. And if there is no cap because of the high-risk pool, then the figure will be astronomical. And if it's over 300 or 301, and then it will go to the high-risk pool. And if it's from 199 to under 300, and if there is an increase of 200%, it's still significant. So I just like to reserve my right to say that we do not agree that the magnitude of increase is so small. Of course, coverage of pre-existing conditions itself is a good thing. But we believe that the figure will not be as low as 5%. And the government is also asked about the estimated increase from 2016 to 2040. That is over a period of 25 years, the increase in average annual premium. I can't agree with the information given. It says here that without the scheme, there is an increase of 4.3%, but with the scheme there will be it will be about 3.5%. But in Hong Kong, we are talking about 5 to 6% every year. And you only give us a figure of 4% or so over a long period of time, 25 years. Why is there medical inflation? It's because of new treatments, new drugs, and of course they will be costly. And another reason is an aging population. Hospitalization rates will increase. I don't see how it can be cheaper. And what about abuses by patients and doctors of the voluntary health, insurance scheme? And as you know that in the future, when it comes to an increase in premium, it can not be just on one single product. It will be for all the products under the scheme. It may not be felt apparently at the beginning, but you see that for those who are ill and those who are elderly, they will keep claiming. But for those who are healthy, they will keep leaving the pool. This is not sustainable for future development. So I don't agree that the increase is so small. Let's hear from the Permanent Secretary first. In relation to 5% of increase with a coverage of pre-existing condition, the consultant is only talking about those who are covered by existing policies, and there is a migration. And of course, if you migrate and if you have pre-existing condition, there will be an extra loading. For very good insurance companies, they may not target individuals. And if you migrate, even with pre-existing condition, there won't be an increase in loading. The additional premium will be shared by others as well. Of course, Mr. Chan is right. Very likely, insurance companies may take the former approach, that there will be 100% loading, or if it's over to 100%, you'll be switched to the high-risk pool. It means that the premium of existing policy holders will not be affected. We have to make this clear. Medical inflation. We're talking about it being slightly over than normal inflation. The 4% is not an absolute figure. It's 4% above the general inflation. And the reason why the figure is lower with the VHIS is because even if you don't do anything, there will be medical inflation, no matter what the figure is. We just want to send the message that there are improvements under the VHIS. Say, for example, MRI, CT scan, these advanced diagnostic imaging tests are included. And certain operations don't have to be done at hospitals. As a result, claim amount will be reduced and number of beds will be released. Pressure on private sector may be lowered. So as a result, the increase will be slower. It's not the case that after this is done, the medical inflation will be this, and it is actually the case that we will not be able to have an impact on the medical inflation. And on top of that, there are some merits with the introduction of the scheme. Well, if this is the answer to an examination, I'm afraid the marker will not be able to give it any points because it's just a lot of hot air. There is no formula showing how it's worked out. You say 5%. I think the important word is overall. Overall claims amount. It means that those who have never made claims, they still have to see an increase of premium by 5%. Because insurance companies do not impose a loading on those with pre-existing condition. How many such policyholders are there? Say for a certain insurance companies, 90 out of 100 policyholders pay the normal premium. 10 of them will see some exclusions, so there won't be any increase in premium. But if you want the conditions covered, that means the exclusions do not apply anymore. And without premium loading, the increase in cost of the 5 people would be shared by the other 90 people as well. And if the exclusions are taken away, how much will the loading be? You can actually work it out. If you can't work these out, you won't be able to arrive at 5%. The 5% is based on something. So if you cover the exclusions as well, how much more will it be? That's my question. Am I right? You need to have this before you work out the 5%. But it's illogical if you tell me that I can't tell you what that is, but I can't tell you what the result is, but I can tell you the 5%. It is based on actuary calculations based on a lot of assumptions. Give us some basic figures, average, insurance companies, how many policies holders pay the normal premium, how many percent have paid loading or without loading covered by exclusions. You have to ask the information from insurance companies. Some insurance companies have 2 strategies. One is to increase loading. Then by how much? That's the answer we are seeking. If there will be a loading for someone with pre-existing condition, how much will the loading be? I want the figure, and I want the percentage of patients that have got pre-existing conditions that will be charged a loading. And it's only with these figures I can assess whether the 5% is reasonable or not. Our understanding of the insurance market is that 90% of the policyholders are normal, and about 10% of them have exclusions. Since they have been excluded, there is no figure. Say, for example, diabetes. If it's excluded, then they won't have the figure. The consultant, when making the calculations, will consider the overall situation, the conditions, how many people have taken out insurance policies, and how much will their claims be. And each insurance company is different. Say, for example, the extent of exclusion of the same condition, say diabetes or heart disease. Since it's excluded, they won't have any data or information because they won't deal with these cases anymore. My understanding is that there aren't many cases when a loading is added. They will simply be excluded. Well, I know that if you have diabetes, then they won't even accept you. They won't underwrite. They won't underwrite you. Well, there aren't many products that will cover you. Well, I asked Mr. Chan. Well, there are different ones. Some of them will cover you with exclusion, and some of them will simply turn you down.
can you tell the permanent secretary if insurers are willing to underwrite the client? What is the amount of loading imposed? They have not considered this factor. From my estimation, there are no such figures in Hong Kong. As such, no calculation is possible. I think it's very hard to, go back and ask them to provide such figures. Perhaps we can work with the Hong Kong Federation of Insurers to come up with such figures. They should have these numbers, right? Some people from the insurance trade told me that, for example, for diabetes, most insurance companies would refuse to provide protection. Please let me finish myself. Some experts in diabetes went to the insurers and told the companies that he can calculate the risk for diabetes patients because he has a lot of figures on hand. And he's also aware that the risk depends on the patient's capability to regulate glucose level. If the patient has a very good family doctor, the risk is actually not very high. It's manageable, and it's good value for money as well for the insurance company, provided that the patient has a good doctor. So as such, the insurance company does not have to bear a very high risk. So we need this kind of information before we can assess whether the 5% is reasonable. You need these figures anyway when you deal with different cases in the future. Perhaps your consultant didn't even conduct this analysis. That's rather obvious. So this is just a wild guess, the 5%. Well, you can say this is an objective estimation or guesstimate. As we mentioned, most insurance companies would refuse the applications altogether, but in other countries, they are rather more successful in case management. Let's assume, let's say Hong Kong is a rather westernized city in Asia. Can you take reference from other countries? I will try. At the end of the day, you need to give us figures before you can convince us that 5% is reasonable. Mr. Chen was very concerned that since you are imposing minimum requirements on the insurance companies, they might be so-called overloaded because 5% might not be adequate for them. So that's why we ask for such figures to justify the 5%. We can try to talk with the insurance trade and if I take a math test and only give the answer and omit all the working steps, do you think it makes sense? I think you should at least give us some simple formulas on how you come up with the inflation rates for medical costs. How do you come up with the medical inflation rates based on the general inflation rates? What are the parameters? The Census and Statistics Department, they would base their forecasts on vegetable prices on various parameters. So the inflation rate doesn't depend on specific commodities. They would consider a series of parameters. They would select some common everyday commodities and look at their market rates in the calculation of inflation. So in the formula, well, they have a fixed set of conditions. And as far as healthcare inflation is concerned, you should establish a series of parameters today to address questions in the future. You can look at historical data and give us a formula and come up with an end figure. And with these parameters, you can show us how these parameters which will change with or without healthcare insurance. So this is a rather more scientific approach. And you have to ask the Census and Statistics Department how they come up with inflation rates. If you are to calculate healthcare inflation, what kind of parameters should you use? You have to report the progress back to us in the future. So are you capable of designing your own healthcare inflation indicator? Will you at least give it a try? You are a full grown-up. I'm sure you are capable of doing that. Time is limited because we have to finish by 4:30. Under paragraph 10, I mentioned 4.3% and 3.5%. Does it mean the healthcare inflation is higher than the general inflation? After the scheme is launched, the figure is 6.5. Without the scheme, it's 73%. If this is the case, you should have a look again at paragraph 10 from 2016 to 2040. The projected premium growth rate of individual indemnity hospital insurance products averages at 3.5% per year. And you mentioned that it's above the general inflation rate, but it seems to be about something else. You should make it clear that it represents an increase. You only talked about the increases. The way you put it right now is very misleading. You are trying to give the impression that 3.5 and 4.3% are rather low, but the actual figures are higher than that. What do you think about my suggestion just now? According to the CSD, they have a formula for the general inflation rate. They would look at commodities in the market, and they have a very concrete formula in place. I think you should do the same for medical or healthcare inflation as well. Healthcare inflation is a rather new concept. Well, you can establish a formula for yourself, right? You should define a formula for yourself. You can, let's say, choose 100 items and come up with the calculations. Since time is limited, I'm sure we have more to follow up on, and so I think you should do more, definitely. And the other question is that what does the time frame look like? Right now, we have established a working group with the insurance trade to deal with the issue of pre-existing conditions, because there are a lot of views on that. And hopefully, in the next 2 or 3 months, we can reach a consensus. And after that, we'll report the progress back to the subcommittee on how we will implement that. So perhaps we can work out time with the Secretariat. Say, let's finish 5 minutes ahead of time. Thank you. Thank you.